Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.
Welcome to Patient Prep Room, a podcast that explores important and often misunderstood aspects of living with autoimmune arthritis and related conditions in Australia. In this new season of Patient Prep Room, we focus on axial spondyloarthritis, axSpA, an often misunderstood autoimmune condition affecting the spine and joints. Through conversations with expert rheumatologists, a physiotherapist, and axSpA patients, we explore the challenges of diagnosis, the role of inflammation in comorbidities, and practical strategies for daily management. Whether you are newly diagnosed or navigating axSpA for years, this season offers insight and support for you to take charge of your health. I'm your host, Naomi Creek, National Coordinator at GHLF Australia. And in this episode, we're talking with Dr. Arupam Raman, a rheumatologist who works at South by Southwest Specialists in New South Wales, and two patients who we met in the first episode, Sherry Cleland from South Australia and Shane Vanderhyde from Victoria, who both live with axial spondyloarthritis. Welcome to you all. Would you like to introduce yourself, Dr. Raman?
So hi everyone, my name's Arupam. I'm a rheumatologist. At the moment I'm working in a private practice in Gledswood Hills called South by Southwest Specialists. I've been a rheumatologist just this year. I finished my training last year.
Wonderful. Thanks for joining us, Dr. Raman. There are a number of comorbidities associated with axial spondyloarthritis. What are the most common ones, and how does inflammation play a role in patients developing these comorbidities?
Yeah, so with spondyloarthritis, there are lots of different comorbidities. The more common ones tends to be hypertension, high blood pressure, osteoporosis, infections. Patients can develop obstructive sleep apnea, and then a few other complications like fibromyalgia, depression, and anxiety. Overall, there's not a very clear reason specifically as to why some patients develop some comorbidities and not others, but we do think it tends to be due to the inflammatory cytokines or proteins that the body releases, different medications with medication side effects as well, the impact of having chronic inflammation, and then the immune system dysregulating. We also know that there's other risk factors like physical inactivity and different lifestyle factors like high weight, metabolic syndrome, so again, weight, diabetes, high cholesterol, high blood pressure, and then muscle loss and deconditioning from chronic pain as well. There are also psychological factors and stress like chronic fatigue and chronic pain, which increases the risk of depression and anxiety. So all of those factors, again, together do increase the risk of patients developing the comorbidities, and therefore it's important to screen when we see patients with spondyloarthropathy.
Wow, so there's a lot of factors involved in these, aren't there? So do people tend to develop the comorbidities fairly quickly over a long space of time?
I think it does vary a lot. So some patients often, as Dr. Yoon spoke about in the first episode, it can be difficult to diagnose axial spondylopathy, and therefore some patients might actually have comorbidities that are long-standing prior to them getting a formal diagnosis. And so, therefore, when we see patients for the first time, sometimes they might have them. However, on the other hand, some patients may develop them later as well, and therefore it's really important to screen for them. I think the other thing is that a lot of patients and maybe other doctors might not know that they're associated. And so when we ask patients the symptoms related to them, then they sort of say, oh yes, I've actually had that for a long time and I didn't know that it was related.
So when they're seeing their GPs for these other comorbidities, so high blood pressure and things like that, and they may have small amount of back pain, initially, I guess it's sort of hard to put those, to sort of piece that together. It could be anything. They could be two separate things, but when can you start sort of seeing though that they're related?
So I think it's really when there's that suspicion that the patient could have an axial spondyloarthropathy. So it's really the type of back pain that they have. So for example, we know that there's lots of different types of pain, and it's really important to differentiate, for example, what inflammatory pain is versus non-inflammatory pain. So inflammatory pain being the sort of classic morning stiffness, improving with activity and worsening with rest and worsening with prolonged sitting, for example. And so once there's that suspicion for inflammatory back pain, then the next step really would be, are there any other features that could help sort of support the diagnosis? So if patients have, for example, tendon problems, eye issues that are related, other joints that are becoming painful, and then putting that together with this could be an inflammatory back pain, it could be an axial spondyloarthropathy, it would then be important to think about the other comorbidities. So then asking patients specifically, for example, about their mood, their fatigue or their energy levels, their sleep quality, checking their blood pressure and doing all of those other screening investigations and blood tests like high cholesterol, checking their weight, that can be related.
And you mentioned about hypertension, which I believe is one of the more common comorbidities. Around 22% of patients with axSpA have hypertension. Is this something that you regularly screen with patients, or is it something they should be getting done regularly with their GP or on their own even?
Yes, I think screening for hypertension is really important. So like you said, 22, even some articles up to 35% of patients with axSpA can develop hypertension. Again, it can be anywhere in their disease course. And it is important to manage because we know it increases their risk of getting cardiovascular disease, so including heart attacks, strokes, and also kidney damage, which can be irreversible or quite severe if it's not treated or picked up late. So I think it's important for everyone to be mindful and to screen for that. So that's both at a patient level, but also at a doctor level. So as a rheumatologist, when I see patients in practice, it's really important to always check their blood pressure whenever I see them. And really we're aiming for what we call a normal blood pressure, so less than 120 on 80. And then of course taking into consideration if they do have any other risk factors for developing cardiovascular disease as well, like diabetes, high cholesterol, obesity, or a family history of either hypertension or cardiovascular disease. So regularly monitoring blood pressure is really important. Also, whenever patients see their general practitioner, they should have their blood pressure checked, and patients themselves at home. So I think patients often do, and they can get a blood pressure monitor at home to check their blood pressure. It's important to check it regularly at the same time every day, write it down in a journal, and then show their doctors. And so really, if they have high blood pressure, if they have risk factors, I think that they should check their blood pressure a few times a week. And if they're screening for high blood pressure, then, for example, once a month, just to see what their readings are. And it's important, the other reason is that often hypertension can be asymptomatic, and so unless patients have symptoms, it might not be picked up. And if they do develop symptoms, they can be things like headaches, dizziness, chest pain, shortness of breath, blurred vision. We always know that prevention is better than treatment.
That sounds like such great advice, Dr. Raman. And prevention is definitely something we should focus more on. Shane, you live with hypertension, and also Dr. Raman mentioned kidney disease. Would you like to touch on a couple of those that you have to live with, as well as your axSpA?
Yes. The hypertension, I think, is family more related than AS related. My mother's got it, my grandmother had it. There's a lot of family history of high blood pressure. But yes, it could be related as well. The medication I was taking that affected my kidneys, my kidney function dropped down to concerning level. So now I see a kidney doctor to go through the process to make sure that my kidneys are going to survive as long as I am. And the other thing I did have was sleep apnea. I don't sleep too well of a night time. I was diagnosed with sleep apnea about 5-6 years ago. So yes, all that does create extra fatigue and extra stress on the body. But with someone who's got axSpA, it's just part of life, unfortunately. You either get on with life or you sit in the corner and do nothing. And if you sit in the corner and do nothing with this disease, you end up worse. My philosophy is have a go.
That's a good philosophy to have, isn't it? Sherry, what are some of the comorbidities? You have a long list, unfortunately, as well. Can you share some more about those?
Yes, I wasn't aware of heart disease or the hypertension and kidney issues being something to watch for with this disease, but like Shane, I do have a family history. My mother had sick sinus syndrome, a cardiac issue where my pulse drops down to 30 or else it goes up to 130, 40, atrial fibrillation. So I did have chest pain for 2 years following a bad chest infection, and I finally asked the GP, could I see a cardiologist? And thanks to a smartwatch, I just eventually printed off some ECGs that I could take with it, and I had a pacemaker inserted within 9 days of showing that to the cardiologist, a defibrillator pacemaker. And obviously the cardiologist also put me on hypertension medication. When I take it myself at home, my blood pressure is fine, but most of the time anywhere else it's elevated. So I do feel better since starting that. The chest pain has eased. So I was surprised that it may be a symptom of axSpA, or it might just be family history in my case.
Dr. Raman, Shane and Sherry both mentioned about the family history of hypertension. I guess it doesn't really matter, where the hypertension comes from, the fact that they have it and needs to be treated. But is there a compounding effect of they have axSpA and they have the genetic factor with hypertension there, that they probably more likely to get it?
Yeah, I think so. I think it does increase their risk of getting hypertension and then having the associated complications related to that. Like you've said, it's quite hard to know how much of it is related to the axSpA and how much of it is related to other risk factors like the genetics or the family history. Of course, we know that that's not modifiable, and therefore what we can modify are the other lifestyle factors, but also treating the axSpA, treating the underlying chronic inflammation that can then improve the blood pressure as well, though it does often depend on how long patients have had high blood pressure for, and also the other factors like some medications that patients with axSpA might take, like anti-inflammatories. Corticosteroids can also increase the risk of developing hypertension. So together, even more reason to treat it closely.
Yeah, for sure. And it sounds like the smartwatches I know wear one myself and have been very interested to see what's going on with my pulse and things like that. So that could be something for patients to get one to monitor these symptoms.
I wasn't sure whether the cardiologist would think it was accurate enough, but I've since heard that they loan smartwatches to their patients so that they can monitor at home. I had a Holter monitor separately for a week at a time, and it showed some irregularity, but not the proper episodes that was really blacking out, basically.
Wow. Yeah, so I guess it's a guide at least to take you to the doctor.
Yes.
And Dr. Raman, is it something that is discussed with patients as a matter of course, these comorbidities when they're going for their regular checkups and things? Is it something that rheumatologists remind their patients about these possibilities of comorbidities?
Yes, definitely. Whenever I see patients with axSpA, I always do ask them the related questions associated with the comorbidities, just as another reminder to let them know what the symptoms are. So firstly, whenever we diagnose someone with axSpA, I always go through the comorbidities, give them some information sheets on it. Often in that first appointment, it can be a little bit overwhelming, and therefore that's why the written information is really helpful. Different resources, just so patients know what symptoms to look out for. And then whenever I see them again as well. I think certainly through my training, I think unless I'd specifically asked those questions, people didn't tell me about them. So that was the most I'd noticed it for something like fibromyalgia, where patients would talk about pain, and unless I specifically asked and screened for the symptoms of fibromyalgia, they wouldn't have thought of it, and it wouldn't have been diagnosed, and therefore it wouldn't have been treated as well. So that's why, yes, definitely always ask questions relating to those things.
Yeah, for sure. And fibromyalgia was my next question to you. It's one of your specialties. Why do some people with axSpA get fibromyalgia, and can having both conditions make monitoring treatment success difficult, as the fibromy may interfere with your assessment of their conditions?
So fibromyalgia overall is common in patients with axial spondyloarthropathies. When we look at different studies, the rates can be as high as 5%, which I think is quite high, especially for something that is underdiagnosed and often quite misunderstood. So fibromyalgia is a central sensitization syndrome. So our our nervous system, which normally regulates pain signals and responds to different stimuli, it perceives pain even though there's no specific injury present. So we say if, for example, a patient has an injury, like a cut on their finger, their nervous system would recognize that there's an injury there. The pain signals would detect that to us, it gets treated, and then the pain improves and resolves. But in fibromyalgia, rather than there being an injury like that, the pain stimuli in this nervous system, it becomes amplified. And so even though there's no injury there, the body still perceives pain. And that pain is real pain. Often people might not know or they might not feel that fibromyalgia is real, but it definitely is real. One of the reassuring things, though, is that there's no damage that's occurring to the body and there's no injury that's present as well. There's a few different reasons or theories why we think patients with axial spondyloarthropathies can develop fibromyalgia, but there's not a specific, clear one reason. And so we postulate that it's related to chronic inflammation that's occurring in axial spondyloarthropathy, heightened sensitivity, and these pain signal amplifications. We also know that patients are more likely to have stress, depression, anxiety, and these are also risk factors for developing fibromyalgia. And so all of these things together can then exacerbate the pain perception. And what patients feel and often tell us is that they develop this widespread pain, muscle skin sensitivity, difficulty sleeping, cognitive issues, so poor memory. People often call it fibromyalgia fog or fibro fog. People can have bowel disturbances, so diarrhea, tummy pain, and bloating, and headaches. Things like sensitivity to bright lights and loud noises, so even brushing against someone, bumping into somebody can be very painful. And because of the pain that they experience and the pain that axSpA causes, there is quite a lot of overlap, and therefore it can be difficult to diagnose and also treat both of them together. And so it's really important to have that holistic approach, take everything in together. Sometimes patients can differentiate what they feel is their fibromyalgia versus their axSpA. That might be because they were diagnosed with one before the other and be able to differentiate. But again, it can be really overlapping in terms of symptoms. And sort of what can help with that is things like a symptom diary. There's a few different scoring tools. So with fibromyalgia, there's the widespread pain index and also the symptom severity score, looking at the different areas of the body that are painful and those different symptoms that patients with fibromyalgia can get, and putting that together with their examination and their blood tests to sort of differentiate which one it might be and therefore treat either one or, of course, both together.
Thank you. That's a very comprehensive answer, and you probably answered the next question I had, which was how do patients differentiate fibromyalgia pain from their primary condition? So I guess it can be difficult for someone who's starting out with some fibro, but I guess it comes down to having that discussion with your rheumatologist about any changes, all the things that you've been experiencing, and the pain diaries or just the diary of how you've been between visits can be really a key factor, can't it?
Yes, that's right. And there are some sort of similarities and then a few differences that patients might notice or that are specifically important to ask for. So for example, the type of pain. In fibromyalgia, patients tend to say that they've got sort of widespread whole body pain. It's not just limited to the joints, but it's also the muscle, the skin, even light pressure. They might call it a constant dull ache. Whereas in axial spondyloarthropathies, it tends to be more localized, either to the spine or the sacroiliac joints or the peripheral joints. That tends to be worse in the morning, worse with rest, and improves with movement. Whereas fibromyalgia sometimes doesn't get better with rest and it can just be persistent and present throughout the whole day. There's also tender points. With fibromyalgia, there's certain areas that might be more painful than others, like shoulders, elbows, hips, knees, neck. But we don't see any swelling when we examine people. Whereas with axSpA, it's usually not specifically in those areas, and there might be swelling as well. There can also be tenderness at the entheses, so where the tendons meet the bone, or with tendon insertion points themselves. There's also fatigue, which generally improves with axial spondyloarthropathy treatment, but with fibromyalgia it can be quite persistent. There's the cognitive symptoms with fibromyalgia, the difficulty concentrating, the memory issues, hard to focus, whereas with axial spondyloarthropathy, generally the pain and the fatigue can contribute, but it doesn't tend to cause as many cognitive symptoms. And with sleep, people with fibromyalgia often say it's hard to get to sleep, hard to stay asleep, and when they wake up, they're still feeling very tired. Whereas with axial spondyloarthropathy, people tend to wake up during the night because of pain. They're stiff in the morning, and then as they move and with activity, their pain levels improve. And unfortunately, both of them can be triggered by things like stress, trauma, and infection, and so it can be, in those cases, harder to differentiate them as well.
Wow, fibro is quite a complex condition, isn't it, with so many variable symptoms. Sherry and Shane, you have quite a number of comorbidities. How have these impacted your axSpA symptoms and I guess other aspects of your life?
Yeah, well, I'll start if that's okay, Shane. And I likewise have now low kidney function. The sodium level drops, which apparently is the one they are more concerned with because of possible brain injury, or it's more of a worrisome complaint compared to other aspects of the kidney function. So we're just monitoring that at the moment. And the cardiology aspect, certainly now I do have more fatigue than ever. The smouldering myeloma, I'm anemic, and I don't know what to blame for the fatigue, but at least in a way it's reassuring that I don't feel guilty. I've always been an active person. Now I feel that I have permission to rest more. I have my craft that I enjoy, and so I'll try and do the afternoon. I do my chores in the morning and rest as much as I can after, and whenever I need. I don't feel guilty about that. So while it is an issue, I've withdrawn socially, I guess, because I don't have the stamina to be bothered, and there have been times with the depression aspect as well. So it is a roller coaster, and it's not easy, but you learn to move on and just enjoy the fact that I have had my 70th birthday. I'm still here and make the best of life. I still do have a lovely family and a granddaughter that was married recently. So there are things to live for. It's just manage them as best you can.
That's wonderful to hear. Shane?
Yes, my kidney function is a concern of mine. Doctor tells me that my kidneys should last until I'm 80, and I reckon 80 is probably not a bad innings when it comes to that. I put up with a lot of discomfort and pain during life. I live a very, very active life. I'm a volunteer at Victorian SES, as well as a couple of other support groups, as in Parkinson's Victoria and Ankylosing Spondylitis Victoria. I get to some end of some weeks and I fall in a heap, but that's the way I choose to live my life. Take every challenge on that comes towards me and just keep going. It's hard some days, but I work full time and I have a reasonably stressful job. I manage a training organisation with 700 students, and that causes me a fair bit of stress during the week, as well as my fatigue that I get.
Wow, sound like you do a lot, Shane. I wanted to ask about the support you have with friends and family and what they think about your condition, and do they believe you when you say you've got other symptoms and things? Because I know we hear from lots of patients with chronic disease that you feel like, you're saying you've got this new symptom, and you want to stop talking about it sometimes. But I know Sherry mentioned the guilt factor, but we really shouldn't feel guilty. It's not our fault. But how do you get around that, and how do you keep that positive outlook when these things are just compounding?
I let everyone know around me what conditions I've got. I believe that everyone knowing what conditions I have, if something goes wrong with me, they can react a little bit quicker. In that sense, they can start on the right track if they see me fall over for whatever reason, that they know that there's one of a few reasons why that might be the case. And I don't feel guilty about that. It does frustrate me that I have so many medical conditions that restrict my life, and it's difficult in that sense. But I reckon knowledge is the best part of it, and if people around you know what you're going through, on a regular basis, it's better for them. It's like anything, if you talk about it, makes things easier and makes people more knowledgeable, and sharing knowledge is part of what I do with the support groups that I support through that sense as well. So it's just normal for me.
Thanks, Shane. Sherry?
I feel as much as I do tell family and friends to a point that often, especially as I've had so many now, that I think it's just they're not really interested unless, and like my daughter has psoriatic arthritis now, so she's obviously understanding, but unless you've been through something, I find even with nursing staff or just general public, they don't really understand what it can be like. And so I also have the issue living where we do of poor medical services. It's so difficult to get GPs to the country that we mostly use a GP practice in Adelaide. That's where I had to go for COVID vaccinations. And it's a worry that, especially with my cardiac condition, that I don't feel safe in the country, really. So, there's my family, lovely, but I don't think they really understand. My husband's very supportive, thankfully.
I'm so sorry, Sherry. It's such a common thing that we hear from other patients as well, where they have family and friends that just don't really get what they're going through. I think they might have to listen to this episode to hear more about what you're going through. Dr. Raman, do you have anything you might want to comment on what they've just talked about?
Yeah, thank you, Sherry and Shane. I'm glad that both of you have some support and you're both working really hard and doing a lot to improve your health. It's very brave, very admirable, quite inspiring. I think it is really hard to manage when people are having symptoms for so long. It's something that's chronic. Patients can have symptoms that affect them every day. And so I think it really is important to have some type of a support network, whether that be family or friends, someone that they can talk to, just so they're not alone.
So how important is it? I want to get back to the inflammation part, because it is really at the core of a lot of these problems we're talking about in this episode. Is it on people's radar about inflammation when they're given the diagnosis of axSpA, or is it more the name axSpA and their spine and the joints and things like that?
I think it's really important for patients to take that role themselves. And I think there's a lot more coming out in general about it. So I often have patients ask me, what can I do other than medications? What else can I do? Is there a role for diet? All really important questions. And I think people are really taking on that role of looking after themselves well. I think with inflammation itself, it has such an important role to address it, and there are a few different aims. We want to improve mobility, we want to lower their pain, reduce the inflammation, improve their quality of life and function. And so managing that really is a combination of both lifestyle measures and medications together. So a few of the more important principles are things like staying active. So what type of exercise can people do? Things that are low impact rather than excessive high impact activity. We know regular movement reduces stiffness, it maintains mobility, it reduces inflammation. And so people find things that are really helpful: yoga, Pilates, swimming and water aerobics, walking, cycling, and then some strength training for joint stability. So it can be really hard to do a lot of those things initially on when the pain levels are high, but we know even doing a little bit per day can really improve things. And people might think water aerobics is easy. It is not. I've done it before. It is very strenuous. And so the people that can do that, they're already taking, quite a big step in improving their fitness. Things like anti-inflammatory diet, so we know there's a role for increasing omega-3 fatty acids, and just a general healthy diet, so plenty of fruits and vegetables, avoiding excessive processed foods. And that's the other important area really is sleep and stress management. So easier said than done to just say stop stressing to somebody, but things like for sleep, having a consistent routine, some relaxation strategies, whether that be mindfulness, meditation, journaling, anything that people find relaxes them, and a good sleep hygiene. It's also important to monitor symptoms and track symptoms. There's a lot of useful things with technology now with different apps and journals that can help people to monitor them, because sometimes patients can forget their symptoms when they come and see the doctor. Having regular checkups with both doctors and their allied health professionals, So patients can see other staff like a dietitian or an exercise physiologist, a physiotherapist, a psychologist, and all of those different people can help patients together. Having regular blood tests and making sure you don't forget any of your medications, whether that be an app or a Webster pack or some type of a diary, an alarm system, a few other general things. We know that smoking increases inflammation, and so quitting smoking is very important. And we all have a role, so both the rheumatologists, the general practitioners, all of their doctors, to support people in reducing smoking and quitting smoking, because that can be a difficult process and that requires some help, having a healthy weight and staying well hydrated. Those would be, I think, the main things that people can do to help control their inflammation levels.
Amazing advice, and we'll be continuing to talk about these lifestyle aspects in our next episode with our physio. Well, it's been such a wonderful episode talking with you all. We've covered a lot of important topics, including understanding some of the more common comorbidities associated with axial spondyloarthritis, like hypertension, osteoporosis and fibromyalgia. And we've learned that a holistic approach, including exercise, diet, stress management and regular checkups, will help improve quality of life and function. Thank you, Sherry, Shane and Dr. Raman, for sharing all your knowledge and experiences.
Thank you for having me.
Thank you.
Thank you.
Thanks for listening to this episode of Patient Prep Room. Click follow wherever you listen to podcasts and join the Creaky Joints Australia community to receive additional resources to help you live your best life despite arthritis. Join for free at creakyjoints.org.au. Creaky Joints Australia recommends that you always consult with your medical provider to ensure you remain at the centre of your healthcare. This podcast was made possible with support from UCB Australia. If you've liked what you've heard, be sure to rate our podcasts, write a positive review, and spread the word by sharing with your friends and family. It'll help more people like you find us.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.